Well, are you up for a treat today? Today, we talk about chronic pelvic pain syndrome, and that includes things like prostatitis, penile pain, testicular pain, all the what we call pelvic itises with one of the greats in this field. This is Dr. Jeanette Potts, who is a graduate from Case Western Reserve University in Cleveland, Ohio, and then completed a family medicine residency in 1994. She took the road less traveled, just like I did, where she decided as a family medicine doctor to become a specialist in urology. And she did get the opportunity from Dr. Andrew Novick, who created a fellowship in urology for Dr. Potts, enabling her to gain expertise in all aspects of urology over the course of the following year. She then spent 15 years at the prestigious Cleveland Clinic and then decided to specialize even further in an area in urology called urological chronic pelvic pain syndrome. Dr. Potts is one of the few specialists who actually cares to see men with pelvic pain, things like prostatitis, pelvic-itis, one of the few. I think her and I are the two that see the most prostatitis, probably even in the country, because I think we understand how the disease works and how the patient works with this disease. In this particular episode that I'm so excited about for you to hear, we talk about neuralgia. We talk about what else is happening down there? What else is happening with the patient? What else is happening with the patient's psychology? How is this affecting their mind? And we take a deep dive into functional syndrome somatic therapy and what it means and how eventually we can do to help patients with chronic pelvic pain syndrome. And lastly, perhaps, is prostatitis a wrong diagnosis? Is it even a real diagnosis? Is it a diagnosis that holds weight? Enjoy this extraordinary conversation with Dr. Jeanette Potts. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Hey, friends, I have some exciting news for you. Between November 19th and November 25th, I am hosting the Prostate Cancer Summit. The Prostate Cancer Summit is a week-long discussion with the best of the best in the world of prostate cancer. We're talking about the best clinicians and thought leaders in natural medicine, the best thought leaders in radiology, the best thought leaders in focal therapy, in diagnosing prostate cancer, in diet therapy, in prostatectomy, in penile health after prostate cancer treatment. This has been extraordinary and fabulous and fun undertaking by me as a host of this summit that I think you're going to find so valuable. This is going to answer a lot of your questions, and you're going to hopefully find confidence and clarity around all things related to this disease that I believe is an opportunity for you to live your best life. So for more information on the Prostate Cancer Summit, please look at the link below on the description notes as it relates to the summit. Enjoy the summit, and I'll see you soon. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my intention and my goal to help you optimize your prostate health, testosterone, erections, and maybe even live better with age. Today's guest is Jeanette Potts, as you know, and Dr. Jeanette Potts, but we'll go by first names moving forward. You know, in the field of, we're going to call it prostatitis, but I think that you're up for a treat here because maybe that's not even the right diagnosis, but we'll talk about that. When it comes to this diagnosis that so many men suffer, who do you go to? if you're a listener with prostatitis, you're frustrated. And guess what? Your physician is frustrated as well. And there's only very few people that I think that can address this condition really well. And one of them is Dr. Potts. So, Jeanette, thank you so much for being on. We've tried numerous times and scheduling and technology, but here we are. And I can tell you how happy I am to have you on my podcast.
Well, I'm very grateful for the invitation. And on behalf of all your listeners, too, I thank you for having interest in this field and for, allowing me to share my perspective.
It's my pleasure. Jeanette, you saw how I opened up this episode. And, I have a patient just yesterday, 52 years old. And so he has this symptom of a pull on his right testicle, right? This constant pull. He rated it a 7, 8 out of 10 oftentimes, but sometimes it's a 2 or 3 out of 10. When I look at the referral, it's prostatitis, right? That was the diagnosis that the urologist gave him. And he says, look, I got this prescription for doxycycline. Was there a urine culture showing anything was positive? No, but that's what was all right. You don't have to fill that, or you probably won't have to fill that ever. Not for this condition anyway. And I guess the way I want to start this isn't it just a egregious misdiagnosis? Is it just so that we can bill? What's happening, and why is this the diagnosis that is so common and affects so many people?
I'm not sure what motivated the NIH Consensus Committee in 1994, 1996 to publish the classification system, but that's the problem. I mean, here we are nearly 30 years later, still using these terms. If you even look at the latest NIH MAP study, they still refer to CPPS, which is chronic prostatitis, chronic pelvic pain syndrome, which that is not a diagnosis. They're two separate disease entities. With chronic prostatitis, really only should be reserved for bacterial prostatitis because that is prostatitis. And the other is chronic pelvic pain syndrome, which really isn't even a diagnosis. It's a presentation of the patient with their constellation of symptoms that are unique to them. And it's up to us as the professionals to decipher which one of the diagnoses is contributing to their symptoms. And I would also tell you that the use of this term in the gender-based bias of bladder pain syndrome /IC is also hugely egregious because bladder pain syndrome is something that we need to define, or actually, as the caregiver, we need to now take that presentation and figure out what's going on. And the interstitial cystitis is a real, finite, rare diagnosis. They should never be lumped together in the same way that prostatitis should never be lumped into pelvic pain syndrome. So that's how I believe it all began. And I like to start many of my lectures demonstrating an NIH encephalitis classification system. And I like to see the audience maybe get a little bit uncomfortable with this. But again, when you put NIH in front of it, people turn into lemmings and they're like, whoa, well, this must be something official. But I point out how ridiculous the encephalitis classification system is, because the most common presentation of the ailments under this system is the headache. And imagine if everyone with a headache had a workup for encephalitis or was empirically treated for encephalitis. How ridiculous this would be. So and then I just say, why don't you all call it out for how ridiculous it is? I made this up. I made up the encephalitis classification system. And here we go. We're going to put up this NIH prostatitis classification system. And we took it hook, line, and sinker. I mean, our approach to the patients, our treatment to the patients, and the way we funded research. So it's just wrong. And I tell you, my practice is like exceedingly pelvic pain driven. And I think in the past 10 years, I've had two bacterial prostatitis. I'm just going to say two prostatitis because I think it's even wrong to add that
Bacterial.
term.
Yeah.
Yeah, because it's an infection. And the other times that it may not be is when we have the histological evidence on our biopsies, or if we're doing an andrological workup and there's leukocytospermia, then that's a different story. That's that category 4 asymptomatic prostatitis. So just an inflammatory process with or without infection.
Right. I've seen one case of prostatitis as defined by you. There's a couple of other cases that are very fascinating, and again, just another handful, where they say, I don't I don't have fever based on taking my temperature, but I feel feverish,
Hmm.
right? And I have these symptoms. I look at that and I hear them, and it's similar to some of the Lyme disease patients that I've seen in the past. Of course, there's a
Hmm.
lot of Lyme disease in the Northeast,
Hmm.
and where they kind of present in not pelvic pain, but joints, pain in the joints, feeling fatigue, and this feverish. The person with, we'll call it prostatitis, would say, I feel feverish. And then
Hmm.
this pain is only in the pelvic area. And that's a very fascinating case where I would either do, in that case, I'm confident to do a herbal antimicrobial approach as I do other things. When they have onset of prostatitis, again, I've only seen one case where there's actually fever 102, 103, then we go to doxycycline or whatever other
Hmm.
medication. I don't use a whole lot of fluoroquinolones or recommend them if I don't have to. What are your thoughts on that? Just to
Oh,
gather
I,
your.
I definitely. Well, that's the other thing too. If I'm suspicious, I will do a localization culture. And the thing is, I used to do localization cultures all the time. Initially, because I was convincing myself, because imagine in the late 90s, in 2000, 2001, I was the only one not using antibiotics. So I really was afraid. So I needed to convince
You
myself.
were an outcast.
Yes. And then secondarily, and I didn't sleep for about a month because I really thought something bad's going to happen,
Right,
but I need
right,
to do this.
right.
The other thing was that, oh, what was it? Oh, so it would do the localization. And then the secondary reason for doing the localization was to actually help the patients, because back then there was a great deal of antibiotic codependency. There's the dependency that I have to write something to satisfy the patient, and there's the patient expecting to have an antibiotic as well because of this prostatitis nomenclature. So that was one part of it. And then gradually I thought, well, I could be more selective. So
Mm.
whenever there's a doubt, you just do the localization culture. And the other thing is, I never believe in giving someone antibiotics empirically unless they're febrile and their urine is abnormal.
Great point.
But if they're not febrile and the urine is clean, I'm like, I will call you. The culture will be ready in 5 to 7 days, and then we can start something if it's necessary. And that also goes against the grain because the Prostatitis Network, the international one, they always said, "Oh, just start the antibiotics and then wait for the culture to come." And I'm like, I don't think it's unsafe to do it the other way. And as busy as all of us are, you can always tell the patient, if you were to get a fever or get sick, just call me, come into the office, whatever. And I have to tell you, that's never happened.
Yeah.
So
And that's a safe approach, even if one is, most of us are practicing some defensive medicine, because who wants to get sued? But that's a great way of kind of covering your assets as well, and yourself. So this 52-year-old patient, and this is a typical scenario. And once again, I care to get it right, not to be right, Jeanette. So if you say, Gio, you screwed up on that one, you should have done this, I'll take it. Don't worry about it. I'm good.
I
In
doubt that's going to happen.
in these cases, I don't order urine culture or anything for several reasons. Number one is because they're not febrile, so
Mhm.
they present with no fever, and I agree with that. Number two, what is the possibility? Sometimes these urine cultures come up positive. They're not, and the patient doesn't have fever. And now we know so much about the microbiome. What's the possibility that we're catching things that, hey, what if this is part of their normal microbiota in their, prostate or in their system? Is that remotely possible?
I think if you just do a routine urine culture, you don't really need to fear that. And if you do fear a contamination or something, you just simply repeat it. In 2002, all the people who were on the prostatitis network, we all met in Gießen, Germany, and it was published as the Gießen Consensus. And it said, and yet nobody in the group did it except me or any of the people who read it.
Mm,
It said, withhold antibiotics until the second localization culture corroborates the
mm,
first.
mm,
Because, as we
mm.
know, Nichols' work shows that 7% of normal controls,
Right.
asymptomatic controls, have positive
Yeah.
localization
Yeah.
cultures. So
Mhm.
it just means make sure that you're not just getting a snapshot of that day, or you want to make sure you have the same bacteria with the same susceptibility profile, and then for sure you're dealing with a chronic prostatitis and you treat it. And when you talk about the antibiotics, this is where I go from one extreme to the other. If someone has an infection, I'm going to blast it, and I don't want them to get recurrence or smoldering, so I'm not going to be stingy. Any other time, I don't even offer it. So it's like this minority where I'll really do it. And when
And
I've
you'll
seen
go
them,
hard. You'll go hard in that patient.
I'll go hard because I don't want them to end up being the guy who's having his sixth bout and now we got to consult ID to put a PICC line or something. I think that when I've seen those cases, it's always been in the background when I hear the history that, oh, I'm a 60-some-year-old guy. I was skiing. I got a UTI, I got a fever, and they gave me 7 days of antibiotics. I mean, that's the guy who needed the 2 to 4 weeks, and that's the guy who needed more. And then meanwhile, you and I see these men who have never had a UTI, have never had any evidence, never had a positive culture, and they're getting 6, 8 weeks repeatedly.
Yeah. Do you go the heavy guns? In my opinion, are the fluoroquinolones. So this is your Cipro or your Levaquin, and there's a lot. Well, there's side effects with all antibiotics. We know more now than ever before, but certainly those tendon rupture, which I saw early back in the early 2000s, a lot before
Yes,
any. It was a black. It wasn't even a black box warning at the time.
I know.
Um, do you go when you think that they should be on antibiotics for 4 weeks or so? Do you go for the fluoroquinolones or you do doxy? What's
I do, but what I'll do is start out the heart, just sort of the way we all learned, like when people come to the emergency room,
Yeah.
start broad if you're going to start orally because they can pee and they don't need to be in the hospital. And then as soon as the culture is back with the susceptibilities, try to get you know, the
The
least
right
inoculation.
match?
Hmm.
Yeah, the right match for that specific culture or micro. All right, so 52-year-old patient, prostatitis. The other thing I haven't done in a while is and this is because of COVID, but the only thing I haven't done in a while is a digital rectal exam. The reason for that is because through COVID, you couldn't. And I
Right.
couldn't for about a year, and I was still seeing all these patients. I don't. It didn't seem to me like I got it completely wrong. Like my approach didn't change. Also, I'm not a physical therapist, so maybe if I was, I can see trigger points and things like that, which I did back in the day and relieved it. But in my opinion, the trigger point is another symptom, not the cause. So I want to dig a little deeper and look for causes, right? And then send them to a pelvic pain specialist. Your thoughts on DREs? You learn it in school, boggy. The prostate feels boggy.
Oh, that's bullshit.
I mean, boggy.
That is bullshit.
I mean,
It's
what is
just an
that, right?
No,
Yeah.
it's just not true. And it's just an excuse to take the prescription pad out. It's just like, if you're doing a 70-year-old prostate cancer screening DRE and you happen to be a little less gentle and he goes, "Ooh,"
Right.
you're not going to pull out the Cipro. But if
Right.
they're 30 and you
Right.
do that, it's like,
Right.
"Oh, that's a justification." I mean, no, everybody's
Right.
prostate is sensitive,
Yeah.
and it varies how you do it. It varies when you're going to be checking it. Well, I have very strong opinions about the PT issue. One is, I crusaded for physical therapy long before anybody did. I mean,
Mhm.
I think the people in California, Rodney Anderson, he and I were the only ones doing that, and that really,
Headache in the pelvis person.
yes,
Yeah. Yeah.
Rodney Anderson, and
Yeah.
and that really tarnished my reputation in the urology world in the beginning, because that was like so flaky. I mean, never mind that orthopedic surgeons have physical therapists, but like, gynecologists could have physical therapists too. But it was really out there that we would do it. So I'm crusading for physical therapy. And then I'm going to tell you, I think a lot of physical therapists, and it is the healthcare system's fault, they put a lot of cream on their tacos. They've gone too far. I feel like I've contributed to creating a
I,
monster.
I, by the way, I love that analogy. I have to, as a good Mexicana,
As a
yeah.
Mexican, I'm a Mexican. I mean, way too much cream on the tacos. I mean, like they're going to treat BPH.
Yeah.
They miss tumors because they're not trained to do it. And I want to remind everyone, physical therapists are not licensed to make a diagnosis.
Mm-hmm.
So when I saw how several people that I would meet at meetings and they would say, "Oh, you don't need anything to treat prostatitis, you just need a physical therapist." I'm like, so you don't even, these guys, you're like, you don't examine them. So you've prescribed, physical therapy is a prescription. This is analogous to prescribing ciprofloxacin for 6 weeks to someone without any evidence, without a culture, and without follow-up.
Well, now for many decades, I've had many people, many men ask me, look, is there a device that I can use to massage my prostate? Because my urologist is not doing it. Quite frankly, no one is really doing it. And for hundreds of years, prostate massage has been really important, actually, for just prostate health and people suffering from prostatitis. Well, now I just discovered our next sponsor who are amazing in their innovation. This is the Malto device, which is a device that is clinically proven to support prostate wellness, designed with an ultra slim flexible structure that mimics the index finger for comfortable targeted stimulation. This device is developed by top urologists, and offers unique benefits to enhancing prostate health with potential improvement in erections and even ejaculation. How's that? Its flexibility allows to adapt naturally to the rectum, reaching the prostate with precision, and it includes 16 customizable intensity levels that can be controlled via a free app, giving user full control over their vibrations patterns for personalized experience. This is an FDA registered device and stands out from competitors for its thoughtful design and ease of use, making it a practical solution for optimal prostate care. The Malto device, guys, we finally got one. I have not been able to endorse any or have any that I've been happy with. The Malto device is the way to go. Please check down in the description notes for more information and a link to the Malto device for prostate health.
It's just wrong. Mm-hmm. And it puts the physical therapists, the ethical ones, it puts them in a very bad position because they're like, oh my God, I'm going to be the first one to stick my finger up there and justify why I'm doing it. That's not their role. Their role is have a prescription from the physician who does this is what I find. This patient needs retraining, what have you, but this is the diagnosis. And I do understand and I respect the fact that, you're humbly saying you don't know how to identify a myofascial trigger point. I give you credit for that because there's lots of urologists who claim that they do, and they don't know what they're doing either, but they claim they do. Or they don't do it, and they'll just say they have these things. But if you practice, if you just go in, and it's very basic things you can start with. The tone. Can someone recruit the muscle, the sphincter around your finger? Can they let go again? Most of them can't. Most of them have so much discoordination. Right. And then the beauty of the human body is there's two sides. And usually one side is worse than the other. So you start realizing, oh, there's this asymmetry. I don't know what it is, but then it's like, okay, I look at my book, that's the obturator internus. And that's what was, bothering there. Sometimes even doing the exam, you can release, you can do a trigger
Yeah.
point release during, and they feel better. And I think that as embarrassed as some people imagine that they would be, or as embarrassed as a practitioner may think they may be, it just evaporates immediately. People feel so listened to
Yeah.
and so cared about
Yeah.
that I will never not do that exam. And now we've got Geo. I don't know how it is in New York, but out here, they will book any person with pelvic pain who shows up at a pain clinic for a pudendal nerve block without an exam.
Wow.
There's no exam because, oh my gosh, God forbid we, even with gloves on, we dirty our hands and touch that part of the human body.
Right.
And there are people that we see who it's just shocking to me. I didn't believe it was true until I actually saw so many people who were either on their way to get a pudendal nerve block or had already had a series of them with no exam. And my patients, for the most part, are sophisticated enough to know that they did not get an exam.
Right, exactly. So before COVID, I did it quite often. I had training myofascial trigger point release. It's a series of books. You may know it. Red Books. It's like the
Mhm.
textbook.
The
Forgot
Trevellans, Simon and
Travails.
Trevell.
Yes,
Mhm.
yes. And I went all in these books, and where else? I mean, even at the time when I first started, there was no YouTube, so I'm just learning from these type of platforms. And I have to say that I got better quickly just
Good.
because through practice. And patients felt, and I was like, well, is this, I'm always trying to figure out, not I don't really care. I actually respect the placebo effect to some degree. Don't tell anybody because that's just the power of the mind. That's just between you and I and whoever's
We
listening, by the way.
we are living, breathing placebos in the
That's
best
right.
sense of that word. It got hijacked. It got hijacked as a sham, as the sham. It's not. It's a beautiful word derived. I have a whole lecture on
Uh,
placebo. Go
yeah,
ahead.
that's our next podcast. We'll
Yeah,
talk about
we're
placebo.
fans.
So, but I was like, I don't really care. But I also want to know. I'm just curious if I'm doing something. Sometimes even a prostate massage, right? That's what's been done for how long? That
Mhm.
is the therapy for prostatitis. And back in the day, even in other countries, the Philippines, I believe, is still a major therapeutic modality. So. So anyway, you're making me think here. You're making me think to kind of go back to that approach.
And you're also protecting the patient from, unnecessary invasive procedures. And
That's true.
I mean, it's just exploded. And in the time you and I have started practicing, there has been such an evolution about how the healthcare is delivered,
Yeah,
but the patient hasn't changed. The anatomy hasn't changed. The diagnosis hasn't changed, and we have to go back to basics.
that's right. I completely and going back to basics is the principles of how I was trained initially as a naturopathic doctor. Hydrotherapy. Who would have thought it that now people have buying plunges and doing cold water plunges and things of the sort. Yes. So typically, so the other thing, correct. So I remember when I was doing it more frequently, these prostate massage and kind of working my way through and feeling for those trigger points, that I had to tell them, look, you're going to probably feel not great for some time after this visit. And then hopefully, and then you feel better because I just inflamed more things. So then I said, look, let's go a little deeper and try. Cause then I also saw, yeah, I feel better a week later. Then it sort of came back. I said, well, there's something else going on here, which is our next part of our conversation. Before I go there, pudendal nerve, you said pudendal block. I'm assume that our listener doesn't really know what that means nor why that's important. So go
Mhm.
ahead and describe the pudendal nerve and why it's so important, particularly in this conversation.
So it's not the only nerve, but the the
Hmm.
the one that we get most concerned about. And again, it's not as common as the internet would let you believe. The pudendal nerve, as well as the posterior femoral cutaneous nerve, which is like coming out the mid area of the buttock, these two nerves take care of the whole saddle area. So that entire area where you would be sitting is innervated by these. And the pudendal nerve has branches that go to the penis, to the scrotum, to the perineum, and the anus rectum. And so sometimes during the exam, you can reproduce some of the pain if you're very careful and gentle going by that area. And it helps to diagnose this, not because you're going to send someone for a block, but because the very same behaviors, the very same exercises and stretches, and the very same techniques in physical therapy to relieve some of the compression or irritability are the same that you would do for myofascial trigger points as well. So it's just important to know, because if it's becomes stubborn, at least in my experience, if it's something that's not having a durable result with again, with the person doing their daily homework, seeing the therapist on a regular basis, and we get to about 6 weeks and it's not durable, then, I go back to examine, make sure I didn't miss something. But then I may want to add a neuromodulating agent or
Mm.
some other kind of medication to help amp up. It just depends. Sometimes it would be neuromodulating if I'm thinking if it's more of a peripheral neuropathy or more of a central sensitization, which I think we'll get into later in this conversation as well. Or I may want to use like a skeletal muscle relaxant to enhance the lengthening of the muscles in the pelvic floor. And I don't believe in using or prescribing medications without explaining how I want to use them as a tool or a bridge. So when I do something like a Valium baclofen suppository or something like that, I'm not saying, oh, put this in when you have a rough day and go to sleep. I'm
Mm.
saying put it in an hour before you do your self-care so that you can be mindful of the effects of this medication on lengthening the pelvic floor and the muscles. And this is why it's also so important that this is not a physical therapy referral, because there are times when we, as the physician prescribing physical therapy, need to intervene to help enhance that therapy or to carry it forward either through neuromodulation or through other medications, and sometimes psychological support too.
I think that's a major one. Certainly, Dr. Anderson wrote quite a bit about that in his Headache in the Pelvic book.
Mm.
So, pudendal block, should we ever? I've never done it. It's not what I do, but is that ever something that remotely possible one should consider doing and can bring some relief?
Yes, and but again, it's something where, I mean, people who are really in the pudendal nerve camp may criticize me because I refer my patients to one person who I know does the exam and I've gotten great results, but it's
Mm.
so rare. I very rarely refer people, but when I refer them, I'm sure that this is what they need. I've already done my own kind of like conservative algorithm, multidisciplinary, and I feel very confident that this is what we need to do and we have a good outcome.
Mm.
Again, people in the pudendal nerve camp may say, oh, I'm probably missing people and not doing it enough. But I do feel that it's often way overdiagnosed.
Mm.
And as I said
Yeah.
before, I'm just astonished what a low threshold people have for injecting and doing radio frequency ablation. And I mean, I've seen it all, like, someone saying, oh, well, the injection didn't work, so let's do radio frequency ablation. I'm like, well, the injection is to be able to test your hypothesis if you need
That's
it.
right.
And then there's this whole other issue of the MR neurograms. And those are, we have to treat those in the same way we would treat the spine. We don't, when someone has back pain, we don't automatically go to an MRI. We make a clinical exam of a herniated nucleus pulposa. So we're making that diagnosis clinically and we're treating them conservatively. Now, if we're going to contemplate surgery, or we're going to contemplate something less invasive, but invasive nonetheless, then we do the imaging. And it just seems that so often, the cart's before the horse, and it's just all about this efficiency, which is ultimately inefficient,
Yeah.
and about profits.
Correct. Correct. And oftentimes it's a significant out of pocket expense for the patient in many of these clinics. Before we move on to further therapies, any look, the way I typically, and 80% of the times is they present with clinical symptoms, and I call it pelvic itis, chronic, that's what I call it, pelvic itis. It comes with prostatitis, I call it pelvic itis, and so forth. And then I just go with the approach that I do, which we'll go to in a second. Is there any other diagnostic tool that you think one should use? For example, I used the CPSI questionnaire to give me some numerical value before and after. What do you think of that, or is there something better out there? I feel like I almost fear like you're going to say something that is not so great about that questionnaire. But go
No,
ahead.
no, no. I use it too, but I first of all, I can't stand that over and over again we keep nourishing this bad taxonomy, the chronic prostatitis symptom index. Oh,
Right.
stop it, we
That's
we
right.
have medical students and nurses entering this in databases, and everything that gets published has it. But it is a tool. The reason I do it is because when a patient says that they really don't feel that much better and it's because they've got depression or other things going on, I can always take their before and after CPSI, and we
Yeah.
can we can build on it.
Yeah.
I mean, it's a good tool to see, how much improvement is there, and that's the only reason to use
Yeah.
it. Because
Sure.
because we don't have anything else objective. I mean, everything
Correct.
is based on what we find and what we hear. Another tool that I wish could be done mainstream, and I need to validate this, is when I was a family doctor, we used to do genograms.
Hmm.
And so I always fantasized that when I had the time and I'd be in a private practice, I would resurrect this practice, and that's what I do. I do a genogram on all my patients. It's very interesting to see how people with remarkable genograms, divorce, alcoholism, because this isn't asking your family like what diseases run in your family. Is there hypertension, diabetes, blah blah blah?
Right.
No, this is about like, were your grandparents involved? What was the relationship like? What was going on here? How did you
Childhood
raise?
trauma kind of things.
Yes, and it's amazing what gets revealed because the patient is watching you construct this genogram, and it,
Hmm.
I don't know, it makes it pretty safe
Tell
to
me
just
more about the
say.
genogram. I don't think I'm familiar with it.
So, there's some symbols that are used, 'cause for publications and things, the male's a square, woman's a circle, the
Yeah.
divorce is two slash lines, and then you have all the relationships, the marriages, things like that.
Hmm.
And then I take a little liberty, I make like it's a, positive relationship or a negative or abusive relationship, things like that. But one time I had I think this really illustrates the point. I had a young man come in who was referred to me for interstitial cystitis, and he's pale, he's overweight, he just looks wiped out, 35 years old. And just talking to him, I'm like, oh god, he is one of these guys who at 35 probably has diverticulitis, because we've been seeing this happening in
Yeah.
younger and younger ages. So the exam confirmed it. He had like all the findings, the left lower quadrant, sleep apnea. Of course, the inflammation and the diverticulitis is what would cause the flare ups of bladder urgency frequency. He had been given multiple courses of antibiotics for the prostate, then multiple medications for the bladder for IC,
Mhm.
and it just a mess. And so when I did his genogram, we're checking it out. His mom is a chemical alcoholic, and we do his little brother, and so I black it out because his brother died. And I said, how did it feel for you being so young to lose your brother? And he said, my mother used to say she wished it had been me instead of him. So immediately, and again, you and we're taught not to do this. We're not supposed to have transference, but I immediately felt like this man never felt worthy of care. He didn't have His mother didn't mother him. So I took care of him. I referred him to one of the most competent but also beautiful colorectal surgeons. I sent him to another therapist. I sent him to get a CPAP. He had his colectomy done, got a CPAP. I mean, the guy's body and face, everything transformed.
Mm.
But I believe that knowing that part of that void in him, is the big part of how I had to treat him. I
Mm,
couldn't just treat him and say he needed this, this, and this. He needed
mm,
mothering.
mm.
So
I
anyway,
cannot tell you the last time I've seen almost any patient at this point, but certainly prostatitis patients. We'll just keep calling it that.
ah!
That I mean, make it easy, make the language easy. I can't tell you the amount of times that I have not done something to that effect. Now I'm going to look into the genogram because that sounds fascinating. But the mind body connection, particularly with this patient population, it is overwhelmingly positive in terms of something. Whether I call pelvic itis or prostatitis, I call it the Ivy League disease. My term. I don't. No one else has called it. Why? Well, there was a period of time I saw a lot of Ivy Leaguers with it, whether they were undergrad or grad school. And it's just they stay in their head a lot, right? An Ivy Leaguer stay in their head a lot, and they cannot, 1,000 things moving at the same time, and they cannot turn it off, and that stimulates the central nervous system, which we're going to talk about. And then I believe that if I were to say, gun in my head, Gio, what's the cause of prostatitis? Well, it's itis, is inflammation. No, no, no. What's the cause? I believe is from the central nervous system that's affecting everything in that area, including how many times you find a patient with prostatitis or urethritis or any itis, and they have irritable bowel syndrome. That's a common correlation. They're sort of connected. Often constipation, all these things. So, I pose the questions oftentimes of if I have a patient who's for example, a New York attorney, and I get the sense like, how happy are you with your work? Oh
I
God, I
know.
hate it. All right. Listen, how old are your kids? Well, they're 12 and 14. All right. So I'm going to give you 5 years. And I'm being generous. What's the 5 year plan? Because
Yeah.
even that alone, that gets them like feeling better. The fact that they know, and I'm giving you 5 years because you have 2 to 3 kids, young teenage kids. I know what that feels like. If they're adults or you don't have kids, it's like 1 to 2 years, figure out your finances, right? And or sometimes I say we kind of laugh, right, a little bit because I have great relationship with my patients, and it says, look, I'm always talking to little Gio and I'm always hugging him. Maybe you want to hug little Robbie, or
Yes.
and I'm not pretending to be your therapist. I'm not qualified, but I've just seen this movie over and over again. So
Yeah.
just that kind of stuff, right?
Yeah. No, I love the hug little Geo. And I'm so proud of you as a man that you go there with your patients because
Yeah.
I think it's just easier for me because, it's I kind of get a little bit of a head start with my gender to address those things. I think that's beautiful. And patients really do appreciate it. I think that there is a reason too when people go through this that they need to just question, is there something big or small that they need to change or modify in their life, because sometimes this is sort of just knocking on the door, and then it knocks harder. And and you always, I'm sure you see this too, where patients will be like, well, but I've always run this way, I've always lifted weights this way, I've always worked this many hours. It's like, well,
Why
it's time.
now? Why
it's catch
now?
Yeah,
Yeah.
it's catching up with you,
Yeah.
and just
Yeah.
because you could do it doesn't mean that was a normal healthy thing to be doing. So it is a bit of a wake up call, and I think it's important to give people permission to go there. And the key is that we're not saying, because our practices are unique, and that we're not saying, oh, I'm going to refer you to a psychotherapist, which means this is all in your head and I'm wiping my. I'm saying I want to take care of all of you, and I'm going to continue to take care of all of you, but we're going to need to address this other part too.
That's right. That's
So,
right.
and then it's very disarming, and it makes it easier for people to accept that care. And I find that maybe over the past several years it's been easier for men to accept having that kind of support.
Well, they have no choice. They're desperate, right? They really have no. They're desperate. Another God, this 30-year-old. I mean, his life is pretty. He's a photographer. He can't work. He cannot work. right?
Mhm.
So there's a lot of that. Let's move on to therapies, which we are talking about, right? Just having the making the connection that there might be some psychological, some trauma. One of my favorite books for prostatitis or pelvic itis or chronic pelvic pain syndrome is a book for healing for back pain by John
Mhm.
Sarno called Healing
Oh,
Back Pain.
yes. Several of my patients recommended it to me. So that's how I
Right.
learned about it. Yes.
That's right. And that's what he talks about. He's deceased, and there's a story there because he was at NYU when I first started and I met him. But he's deceased, but it's transformative work. So let's talk about central. It's a tongue.
Sensitization.
Yes, it's a tongue twister for me. But go
Yes.
ahead, go for it.
Okay. So I am going to put, now I'm going to put little cream on my tacos. Back in 19,
Well, you can,
okay.
as a Mexicana, you can. I can't. Well, maybe I could. Go
But
ahead.
now I'm going to put a little extra cream on my tacos. Back in 1999, one of my colleagues at the Cleveland Clinic in rheumatology, he gave me an article from the Lancet called Functional Somatic Syndromes by Wesley. And I read it, and I had already done a lot of the crusading for physical therapy.
Mm-hmm.
And that just changed my practice
Mm,
because I'm like, okay, I'm going to look for functional somatic. I mean, I'm going to look for the myofascial trigger points. I still believe in that. I still want to do it. But I knew that was not the end all be all. And
mm,
reading that article just was transformative. And every surgical and medical subspecialty has their diagnosis, their brand of functional somatic syndrome, and it represents about 35% of all the outpatient consults. On the list, there was no prostatitis. So I went and did a chart review of my patients seeking second opinion for prostatitis. And I found that 65% of them met the criteria for a functional somatic syndrome. And I presented it at the AUA, and I just said, this is a functional prostatitis is a functional somatic syndrome. It's not a urological condition, much less a prostate condition. It's
mm.
a global problem. And I would submit to you that had I done the study prospectively, that number would have been higher because I was just looking at the criteria without having asked the question in advance.
Mm,
And since that time, I'm not sure of the year, I think it might be 2007, a man named Muhammad Yunus changed the name from functional somatic syndrome to central sensitization. And now the NIH map is they're not looking at it that way, but they are trying to be multidisciplinary about it. And one of the papers that came out a few years ago from the map showed that these patients, 70% of them, men or women with pelvic pain, if they drew their pain map, they have pain outside of the pelvis. They have
mm,
symptomatology outside of the pelvis.
mm,
So, by definition, a functional somatic syndrome or central sensitization syndrome is when people have overlapping diagnoses. They have Globus syndrome, they have tension headaches, they have non ulcer dyspepsia, they have irritable bowel syndrome, they have sick building syndrome, maybe the Lyme disease, chronic fatigue. So, it's just every single specialty.
mm.
So when you start interviewing a patient, you for me, I already get like the red flag. I'm like, I'm still going to be doing a physical exam looking for other diagnoses, but I already know this person is meeting this criteria for CSS, the chronicity of their illness, the emotional drain it's causing, the fact that, oh, yeah, 10 years ago when I went through a divorce, I had this non cardiac chest pain. I had to go to the emergency room to get treated. And of course, oh, yes, doc, my bowels are just torn up. And, you know,
Mm.
and you just keep checking it. And about 50% of people acknowledge having some sort of psychological problem, depression, anxiety, things like that.
Absolutely. I definitely, wow. So this is great. I'm going to look up those papers and incorporate that. I think I do that, but I just didn't know. I always said, look, the central nervous system is very much involved here, particularly
Mhm.
the sympathetic nervous system. So I'm trying to stimulate the parasympathetic nervous system either through acupuncture or deep diaphragmatic breathing, which we go through that process. we talk about catastrophizing and things like that, which many of them do, and things like that. The other thing I say, and there again, I like your opinion here. I say, look, with some nutraceutical herbals and things like that, I think the inflammation will go down. I think you'll feel better. I think there's a few nervines in the herbal world that can calm down nervous system very nicely. All these things, but please understand that every man, including me, who does not have a diagnosis of prostatitis, always feels something awkward in their growing. A pull here, a tug there. This is part of our normal being, but we don't pay attention to it because we've never been an 8 out of 10.
Mm-hmm.
So we are all a 2 out of 10, sometimes even a 3 out of 10 down there, and we don't pay attention to it. We just keep it moving.
Mm-hmm.
I say that because you may be a 2 out of 10, 3 out of 10, but now you're catastrophizing and say, oh, here it comes again. Oh, and now now that's perpetuating the problem. Your thoughts
Exactly.
on that approach?
Yeah, exactly. I mean, well, that's even when something starts out as a 1 out of 10. It just depends on where your state of mind is.
Exactly.
I think Stephen Kaplan years ago showed that men previously diagnosed with prostatitis did in fact have a pseudodyssynergia of the sphincter, and so he called it more of a voiding dysfunction. And I'd rather say no, it's pelvic pain with one of its many manifestations.
Yeah.
But he found that in that group, there was an overwhelmingly high representation of firstborn males in that group. So that's another thing I do with the genogram. And I realize it's a little outdated to do the birth order thing, but it is very
Mm.
interesting how firstborn males will have a little bit more of this compulsiveness. So for example, with this revving up, people are working around their house, they injure themselves, and it's a 10 out of 10, 9 out of 10 pain. And then you just say, oh, you're such a klutz, and your brain turns it off so you could keep doing your work. But now you get a 1 out of 10 kind of irritation in the groin area. Last month, your uncle was diagnosed with prostate cancer, or your roommate in college got
Yeah.
diagnosed with something. You maybe had unprotected sex 2 weeks ago, and you're like, oh my goodness, what is it? And now you're actually focusing on a part of the body that is already super innervated, super private, super intimate, all this destiny, your sexual identity, your intimacy, it's all wrapped up there. So anything that's 1 to 2 out of 10 can immediately become
That's right.
an 8 or 9 out of 10. And then you add to that someone who, as you alluded to, someone who is a good thinker, a good an analyst. These people they're very successful, and they need to know that this is who they are. So you embrace this wonderful person you are, who's meticulous, who's conscientious, who's thoughtful. But now we got to like rein it in a little bit.
Yeah. How do
so
we
so you and I
use the
have a
dimmer?
similar.
We dim it down a bit. How do we do that? And they're saying, hell, I've been very successful. I get rewarded for being the way I am. Why
Yes.
would I change? Why would I change?
Yes.
And they cannot get out of their heads.
Yeah, so the one thing to do that I would do a lot when I was doing prostate biopsies, because I just
Hmm.
instinctively felt like, okay, what would I do? And I would make sure I would, if does the patient have a similar personality as I do? So I would say, are you worried about this? I mean, like, what is the concern you have? Blah, blah, blah. So then together I would like hold his hand through the worst case scenario, and just anytime you're worried about something, just go to the worst case scenario, and then we're going to be like, well, look, you've got this resource, you know how to do this, you could cope there, and then you can like back up to like what's more realistic that may occur more probably, and then I'm equipped to handle it. And I think Dean Tripp uses that method when our pain patients are catastrophizing. It's
Mm.
like, because okay, you are so compulsive, you are so thoughtful, let's go to the worst case scenario. You're going to have this the rest of your life.
Mhm.
This is never going to get better, and we know this is not true, but let's just go there.
I'll go there. I'll dance with you. Like I tell my patients,
Yeah,
you want to go there? I'll go there. I'll dance with you. Let's
yeah,
go. Let's
yeah,
go. Let's see. You
yes.
know, yeah.
And it's not so bad because then
Yeah.
you realize, well, no, I have all of these things to be grateful for. I do have great resources, and we can make it work.
Amazing. You know, I think we hit a lot of key areas here, Jeanette, and I'm so grateful once again. I mean, this is I've learned. I just when I think this is why I love my profession. Just when I think I have it down, like what else can I learn? Well, I have a few takeaways here. Any final
Oh,
thoughts as to what the listener can do, particularly the listener, the practitioner, but or the listener? There's some practitioners that listen, but the patient, the self health advocate, who look another thing that we have not discussed for them to do as a final thought, and where can people find you?
oh, okay. Well, you can find me Vista Urology. That's how you find me through just Vista Urology or my name.
VistaUrology.com.
Yeah, yeah.
Yeah, we'll
So
have it in the
with
show
with
notes. Yeah,
the V.
that's right.
As Hispanics, it's like, no, be grande o be chiquita? No, no,
Exactly.
be chiquita, be chiquita. So
Final thoughts.
my final thoughts are that, our healthcare system is broken.
Yeah.
I'm sorry to end on such a sad note, but it is
Yeah,
broken.
but it's true.
And there are some individuals who, coming out of residency or through time, they really did have interest in this, but the system kind of beats it out of you. You almost have to break away
Mm,
and be on your own, which is very sad. In the meantime, I just want people to realize that the healthcare corporations and the insurance companies and all that, they are enjoying profits while we as doctors resent our patients. Because they're fomenting that resentment
mhm,
of our patients, and they're also fomenting the resentment that patients have towards physicians. And I just see them as these wicked, wicked puppeteers, and just letting us go at it. So I would just ask patients to be more forgiving of their individual doctors who are just as much victims as they are by the system. And then what they
mm,
need to do is to be very mindful of, like, be prepared before you go to the appointment. Have a
mm,
list,
mm,
try to keep it to one page,
mm,
be organized, make a timeline. All my patients, I ask them to make a timeline
mhm,
in one big column with a little
mhm,
column on the side to put any unrelated that
mhm,
they may think is unrelated, emotional or stressful life event in the column of their timeline to the right. Be organized. Don't take medical records to see people like Geo or
mhm,
me,
mhm,
because that is a big waste of time. It's
mhm,
cut and pasted electronic medical record. I guess I just want patients to be better educated about what doctors are up against. And then I want doctors to not be afraid to speak out. I realize that the systems think that we're just cogs in the wheel, but if enough of us
mhm,
speak out, then it's ultimately what we wanted. We don't want to continue suffering moral injury.
mhm.
We're not burnt out. We have
Yeah.
moral injury that we can't do what we think is right by the patient, or that, someone's going to force a template on me, and then I have a complicated patient and I only have 15 or 20 minutes to see
Mhm.
them. So this is my take home message, because you were with a group of people and they'll say, oh, doctors need to fix the problem. And then you're with another group of people and it's like patients are so demanding and unrealistic and blah, blah, blah. Both are true.
Yeah, exactly. Yeah. There could be two rights. And I think hey, thank you. That's very powerful. Thank you so much.
Thank you, Gio. Thank you, everyone.
Everyone, look, I hope you enjoyed this. I wouldn't say it ended with a downer. I would say that this is real. And sometimes we just need real, honest information in order for all of us to do better. And look, continue being a self health advocate. You're the captain of this ship. And there's a lot of great information a lot of poor information on the internet as well. I would say that a lot of it is actually not as good, but there's a lot of good information where you can find value and do better and feel better and take matters into your hands and then make a decision that you're involved in, not just your doctor. So everyone, thank you for listening. Hopefully you found this useful and valuable for you, and much love, and I'll see you next time. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.